Hello, my name is Tobias Welte. I'm the head of the Department of Respiratory Medicine, Infectious Disease and Intensive Care at Hannover University, and I have the pleasure to give you a short talk about where I would put my money in with regard to treatment options for COVID-19. As ever, please find my conflict of interest statement. So I'm involved in a huge number of trials with regard to COVID-19, either treatment trials and vaccination trials. If you look to the NIH Gov clinical trials website, and I did it this morning, you can find more than 3,000 studies which are running yet for COVID-19 or SARS-CoV-2 virus. A lot of these trials are observational trials, but there are more than 500 randomized controlled studies which explore new substances or new vaccines with regard to COVID-19 disease. Before I start to show you, and I heard this during the recent talks, what is available in different issues of COVID-19 treatment, I just want to give you a very short introduction into the pathophysiology and immunology of COVID-19. So SARS-CoV-2, the coronavirus, which is different from the SARS-CoV-1 virus, which appeared in 2002 in a huge number of circumstances, is an RNA virus which binds the spike protein, and here especially the S protein of CoV-2 binds to human ACE2 receptors, human ACE2 receptors which are present in more or less every organ system. And I will show this later on, via these receptors, the virus is transported into the cytoplasma where it uses the host cell system to be reproduced. Here, from a currently published paper in European Journal of Pharmacology, a cartoon how it works. So COVID-19 binds to respiratory ACE2 receptors, also ACE2 receptors present in the nase and the other parts of the upper airway. Then it reaches the cytoplasma via RNA-dependent polymerases. It's replicated, and the replicated viruses are packaged and released again outside to the airways. If you look to the different stages of COVID-19 disease, and this makes it totally different from other kinds of respiratory viral infections, the first stage is the viral response phase. So this is a phase in which the virus is replicated and viral load is increasing. In a second phase, the host response, first driven by Th1 and Th2 lymphocytes, is activated, and as a consequence of the host response, a cytokine storm is initiated, mainly driven by pro-inflammatory cytokines like IL-1 and IL-6, which is very special for SARS-CoV-2. At the time point of the increase of the host inflammatory response, viral load drops down, which means in the main phase of the inflammatory response, the virus is very often no more detectable or the viral load is really low. What we learned during the last months is, yes, Corona SARS-2 virus is a virus which first affects the upper airway and the respiratory epithelium. However, in some patients, and it's unclear why this happens, there is a spread of the virus into the circulation, a systemic infection by viremia, and in a second phase, no more epithelial cells are affected, but endothelial cells. Corona SARS-2 virus had been found in more or less all endothelial cells of patients who had died. And this endothelial involvement leads to two distinguished issues. First, there is thrombotic formation in the microvasculature, as shown here in a paper published by the Zurich group in the Lancet. And this leads to thrombosis and right-left shunting as a consequence of this. In addition, shown by my group in the New England Journal of Medicine, there is an increase of generation of new vessels. However, these new angiogenic mechanisms lead to defective microvasculature, and in this not functional microvasculature, local thrombosis also play a role. Taking this pathophysiological point of view, there are currently 4 strategies which are explored. Antiviral therapy, and the current standard treatment is remdesivir, which has demonstrated in 2 New England Journal of Medicine studies its efficiency. However, the problem with the antiviral strategy is if you use it early during the course of the disease, it may work. But for patients admitted to the ICU, in most of them, we have passed the viral stage of the disease and started with the hyperinflammatory state. And as I said before, in this, viral load does not play a role, so antiviral strategies are not very likely to work. For the second phase, immunomodulatory strategies seem to be more beneficial, and it has been shown in the recovery trial, also published in the New England, that dexamethasone is effective even in patients on the ICU to reduce mortality. The third part of treatment option is anticoagulants, as thrombosis formation plays a major role in the first phase of the disease, and the right-left shunting, which is the main reason for the severe hypoxemia of more severely ill patients, is due to coagulation properties. Heparin is the current standard treatment. The fourth option for the future is vaccination. If there is a chance to protect patients from Corona SARS-2 virus, then we will see a reduction in COVID-19 patients, and this would solve a lot of problems which are presently aware together with COVID-19. Let's come back to antiviral strategies. Besides remdesivir, what you have seen in one of the recent talks, there are several strategies which are explored, including anti-spike protein antibodies, protease inhibitors, serine protease inhibitors, and ACE2 receptor blockers. All of this is to reduce the transmission of the virus into the cell. This could be a treatment strategy in the early phase of the disease. However, it's unclear whether it works, and first phase 2 studies are underway. With regard to anti-inflammatory and immune modulatory strategies, anti-IL-6, anti-IL-1, JAK inhibitors, and other drugs which are well known from other rheumatic or inflammatory diseases had been studied. The first studies about anti-IL-6 and anti-IL-1 does not show any efficiency, and it seems to be that these treatment strategies are either started too late or are too specific to show a general outcome benefit. Other strategies include repair strategies, mesenchymal stem cell therapy, or inhaled GM-CSF, which induces stem cell proliferation on a local level, but study results are not ready yet. And personally, as I use these kind of treatment strategies, I know these kind of treatment strategies from RDS, I'm not so positive. Anticoagulants, heparin is used normally. There are a lot of open questions with regard to what kind of heparin has to be used and what kind of treatment schedule should be used. Studies using thrombocyte aggregation inhibition by ASS or other ones are underway, and very specific inhibition of coagulation factors are part of clinical studies. Anticoagulation seems to be a very attractive issue for the future. Last but not least, vaccination is the most attractive issue, and there are a lot of strategies to develop vaccines. I will not talk about this, adenovirus vectors, mRNA vaccines, and others. All of this is in phase 2 and phase 3. It's unclear whether the immune response is good enough to show protection, and we have to wait for the future. So, to conclude, where I would put my money? Well, altogether, if vaccination will work, and I would say the likelihood is about 20 to 40%, this will make most of the money. And if I should invest, I would put it into vaccination strategies. Besides this, I personally find anticoagulation the most attractive, and this is why I invest my university grants mostly into this strategy. Thank you very much. Have a nice day, and I am open for questions in any way.